So for the eye assessment, you would start off by inspecting the outside of the eye. This includes the eyebrow, the eyelashes, the eyelid, the lacrimal apparatus, pupil, cornea, iris, sclera, conjunctiva, and you just want to make sure everything looks intact, functioning, and nothing looks irritated, ripped, red, or any abnormalities. After that, you want to do the visual acuity test, and basically what that is you can have the patient read a standard size text, so like a newspaper, and see if they're able to make that out. And then you can also do this Snellen's chart, and that determines the distance they can see while reading. So if they're 20/20, then that means they can read at 20 feet. Other people can read at 20 feet. And so if their vision is worse, then the number will get higher, and so on and so forth. Far-sighted people can't see what's close to them, so reading a newspaper would be difficult, and they would need reading glasses. But nearsighted people can't see what's away from them, the distance, so they wouldn't get a good score on the Snellen's chart because it's a distance reading. After the visual acuity, you would do the muscle functions. So you would do oculomotor, trochlear, and abducens. And just want to inspect the eyelid and where it lies and if it's drooping. So you just want to check that with the eye function, so blinking, staring, just like looking at their eyelid. Then what you would do is you perform a cover test. So when you're doing a cover test, you cover the patient's one eye and you have them stare straight ahead at an object, so like a picture of something. And then when you uncover their eye, the covered eye should also be staring straight, just like the other eye was. This is to show that just because the one eye is covered doesn't mean it's out of focus. So if a negative result would be that if you cover the right eye and the left eye is looking straight ahead at the picture and you uncover the right eye is drifted off to the side, or it's down, or it's up. It's not equal with the left eye. So you want them to be equal and automatically be looking in the same direction. The corneal light reflex is when you're standing about 12 inches in front of the patient and you point your pen light while it's on to the bridge of their nose, and you want to see the light reflected in the same exact spots on both eyes. If they're not reflected, if you don't see the reflection in one eye, or the reflection's completely different from the other eye, then there could be something further that's wrong with the eye. When you want to evaluate the pupillary response, you have the accommodation test. And that's when the patient is following your finger or a pencil or a pen or your light pen, whatever it is, in and out. So when you come in, you want to see the patient's eyes turn in and follow it. And you want to see the patient's eyes focus when you bring it back out. If their pupils don't fall inwards, then they're not responding to the test, and there could be nerve damage or something else going on. And then the direct consensual response is what you would do for a concussion. You see it most with that. You usually want to get a darker room. People sometimes cover the patient's eye and then do it, but you want it to be kind of a little darker. And you take the pen light while it's on, and then you put it over the pupil, and you want to see it restrict. In other words, like pinpoint almost. You want to see the pupil get smaller. If the pupil dilates, so if the pupil gets bigger, it can indicate a concussion or something going on neurologically that's wrong. So you want to see the pupil restrict and how long it takes for it to restrict, if it's a slow restriction or if it's immediate like it's supposed to be. So then you'd move on to the ophthalmoscope, and that's when you take the light and you look through the light and you kind of just look into the eye. So with this, if you're checking the patient's right eye, you want to hold the scope in your right hand and look through your right eye with it. So right hand, right eye, right eye. If you're looking at the patient's left eye, you want to hold the scope with your left hand and use your left eye to look. Because your face gets so close to the patient's face, if you don't do left, right, and you look at the patient's left eye, but you're using your right eye and right hand, you're going to be in a very awkward situation because of the way your faces line up with each other. So when you're doing this exam, you want to look for the retina, the optic disc, the macula, and any veins and arteries. And there are often, some of them are hard to find in the eye. You have to really know what you're doing to find like the arteries and veins and know exactly where they are and what they look like. But that's what you look for when you're looking in the back of the eye. So the assessment of the ears. Basically, when you start with the ears, you want to inspect the external canal. So anything you can see without going into the ear. And you want to look at the size, shape, pinna, lesions, swelling, redness, conditions, whether it's dry, cracked, even the hygiene of it, because if you can see earwax oozing out, that can indicate what's going on within the ear. So it's important to really pay attention to the outside of the ear. So when you use the ophthalmoscope, you're looking on the inside of the ear and you're looking for the tympanic membrane. And tympanic membrane is usually a grayish color, shiny gray, like a pearly gray color. That's a healthy tympanic membrane. If there's fluid behind it, it tends to be red, maybe a little bit inflamed, and you can see the fluid that is behind it. Like I said, you want to look for the color, because if something's off, it could be red and irritated. It should be a pearly gray color. You want to see the integrity, if it's ruptured, broken, or anything like that, because you can rupture your eardrum. It can be extremely painful. It can cause problems in the future. And you want to look at the cone of light when you're shining light in there. So you want to be able to look for all that. So the test that you would perform for the ear, the first one is the Weber test. And the Weber test is when you're using the tuning fork and you bang it on your hand and you place it in like the middle of your head, the client's head, and the vibration should be heard bilaterally, equally, both ears. One should not be louder than the other, one should be muffled, they should be equal bilaterally. So if you have conductive hearing loss, conductive means that there's some sort of blockage. It could be wax, it could be if a little kid put something in their ear. Conductive is any blockage. So if it's a conductive hearing loss, if you have conductive hearing loss in your right ear and you do the Weber test, the vibration would be louder in your right ear because of the blockage. It echoes. it'd be louder in your right ear. So for conductive hearing loss with the Weber test, whichever ear is the bad ear, that's the ear you're going to hear it louder in. So sensory for the Weber test, sensory is any sort of nerve damage that's done to the ear. That's, you usually don't do it yourself. It's just over time, it's age, it's anything like that. So nerve damage for sensory with the Weber test, you wouldn't hear anything in the ear that's bad. So if your right ear is bad and you know something's wrong with your right ear, and we put the tuning fork on your head, you wouldn't hear anything in your right ear at all. That would indicate a sensory issue with your right ear. So the Rhines test is comparing air conduction to bone conduction. So you want to take your tuning fork, bang it again, and put it on your mastoid process, and then have the client say when they can't hear it anymore, the vibration. And when they no longer can hear it, you take it and you hold it up to the ear. And that's your air. And then you want them to say when they can't hear that anymore. It should be that air conduction is greater than bone conduction. So they should hear it longer next to their ear than they can hear it on their bone. So if it's a conductive hearing loss, it will be the opposite. You'll hear it longer on the bone than you do on the air conduction. Another test you can perform is the whisper test. The whisper test is, we use this during the neuro test. It's when you stand behind the patient and you whisper something to them, and you want to see if they're able to hear it. Because an average person can hear a whisper. I'm not saying too little, like too quietly, but like a normal whisper an average person can hear. The Romberg test is for balance, because with hearing comes balance. That's why a lot of times when you're deaf, you have a hard time with your motor functions as well. So the Romberg test is for balance, and you just close your eyes and stand with your hands to your side and basically just see if you can maintain your balance. So for the eye exam, you're testing the the ear exam, you're testing acoustic nerve and hearing and equilibrium. And you want to make sure equilibrium is intact. Your hearing is the main reason why they do these tests, and make sure you can hear and figure out if you can't hear, why not. And with that comes the acoustic nerve. So that's all you need to know for hearing, the ears and the eyes.